Thank you very much for joining me for this lecture on research methods in relation to public health for eye care. My name is Professor Claire Gilbert and I co-direct the International Centre for Eye Health. In this lecture I'm going to cover what we mean by public health, what different elements does it have, and then I'm just going to focus on the first element, which is gathering the evidence that you need from populations to be able to implement a public eye care programme. So this is how public health is defined. It's all organised measures, be they public or private, to prevent disease, promote health and prolong healthy life among the population as a whole. So it's not dealing with individual patients and their individual problems, nor is it dealing with specific diseases. It's very, very broad in scope and has as the goal improving the general health of the whole population. So it encompasses a very wide range of different elements. So the main functions of public health are threefold: to assess and monitor the health of communities and populations, and to identify priorities, so who in the population is most likely to become sick, or who in the population is already sick, why are they sick, what health conditions do they have, and who needs to be prioritised for services or for other interventions. The second big building block is using and formulating public health policies, and by policies we mean the decisions that are made by those who are responsible for resource allocation to solve identified local or national health problems and priorities. And then the third element is implementing those policies, so the decisions are made ideally based on the evidence that's gathered through the processes of assessment. Policies are made and then the policies are implemented to assure access that are services that are appropriate and cost effective, and this can also include interventions for health promotion and for prevention of specific diseases. So again, the focus of public health is not just on providing services for the sick, it also involves health promotion and trying to prevent illness in the first place. So in this lecture I'm going to be focusing on the very first word of the first building block of public health, which is all about assessing health needs in communities and in populations. So I'm now going to take you on a journey, and I will want you to go or imagine you are in this region which we've called Brono Land. It's quite varied. It's got a population of about 8 million. There's a big river running through from the northeast up to the southwest, which ends in a swamp up at the top here. And down here, this is a fairly fertile area where there is arable farming, quite heavily populated. This area here is very, very fertile because it's beside the river, where there are plantations of mangoes and date palms, and also they're able to grow rice and other crops like that. And then in this area here, it's very dry and arid, and this is inhabited by mainly nomadic pastoralists. So it's a very varied region, and the infrastructure is not brilliant. There are a few roads and a few minor tracks. The capital city is up here, located on this main highway and on a river, a very typical location for the regional capital. And there is a general hospital, but there's no eye clinic. So I hope you're there in the hospital. And the general doctor who's working in the hospital goes to the regional health authorities asking for support to provide eye care services. And the reason he's doing this is because he has noticed a lot of patients coming to the hospital who are blind or who've got serious eye problems, but there's nobody there to treat these patients, and he feels very helpless and doesn't know what to do. However, instead of acquiescing, the Minister of Health started on the first of many questions, as you will see in a moment. And he wasn't satisfied to be told that a lot of blind people were coming to the hospital. And he wanted to know a lot more about the situation before committing limited resources. So a question to you now is, what information could the general doctor provide quickly, easily, and at very, very little expense? So I'll just give you a moment to think about that. Well, what the doctor could provide very quickly and easily is information on the number of eye patients who've come to the hospital over the last month or so, and what eye problems they had, whether they were blind or whether they had other eye conditions. So this is called facility-based data. But there are great limitations to the data that are collected from facilities. And I just want you to think about why that might be. Data collected from facilities is highly likely to be very biased, and by that we mean that the people who access the services with eye conditions may not be the same as all the other people in the population who also have eye conditions but who do not attend. That's very easy to imagine that the people who are more likely to access eye services are going to be people who live nearby, the people who are better educated, the people who've got access to transport, or they've got a son or a daughter who's willing to bring them. And so the causes of visual loss or blindness in those people are likely to be the diseases that present to the eye hospital. And now if you think about it, there are other people out there in the community who are blind. Maybe some of the children in that arid area are becoming blind from vitamin A deficiency. There's no road, there's no infrastructure, there's nobody to bring them, they can't afford the transport. So that child doesn't get to the hospital and so is not included in that facility data. And this is what we mean by bias. So facility-based studies can only give you a little snapshot of what might be happening in the community, but those data cannot be relied upon to tell you about the public health problems of eye conditions in that community. So this is what the general doctor did. He collected a list of the number of people who were coming to the general hospital and what was wrong with them, and presented this to the Minister of Health, who did seem to agree that yes, there were people who needed services who were coming to the hospital. But then he started asking more questions. So if an ophthalmologist were to be appointed, what kind of equipment would that ophthalmologist need to be able to meet the needs of the population? Note, this Minister of Health is thinking like a public health person. He's not thinking about just the people who walk through the door. He is thinking about the eye health needs of Bronerland, for which he is responsible. So the next question to you is, what kind of study would be needed to provide this kind of information? So the answer to that is a population-based cross-sectional survey. And these surveys are undertaken where you go out into the community and you very carefully select a sample of the community who are examined to determine how many of the sample that you examine have eye conditions or who are blind, and what the causes of those conditions are. It's then possible, if you have collected a big enough sample in a careful way, to be able to make inferences about the whole population from which your sample came. So once you have prevalence data, which is defined as the proportion of the population who have the condition of interest, and you have data on the causes, you can then do a very simple formula to find out the number of people who are, say, cataract blind in the population. So let's say we do a population-based survey in Brunoland, carefully selecting a sample. The sample is examined, and 2% of people aged over 40 are blind. We usually do blindness surveys in the elderly. So 2% of those aged over 40 are blind, and half, so 1% of the population are cataract blind. You can then work out how many people in Brunoland are blind from cataract, and that's called the magnitude. So this is the value of population-based cross-sectional surveys. They allow you to work out the number of people who are blind or visually impaired, or the number of people who've got specific eye conditions in a population that you're trying to serve. But it's very, very important that the sample that you examine in the survey is representative, or like a little microcosm, of the population of the region. So here we now have got a bit of the population distribution in Brunoland, and you'll see that 2 million people live in the capital city, 1 million live in this arid area down here, another million up here, and half the population live in this very fertile area. That would be a very typical distribution of the population. So if we translate that into a percentage, a quarter of the population live in the city, half live in this fertile arable area, and 12.5% and 12.5% live in these drier areas. So if we were going to do a survey, we should not just focus on the easily accessible urban population, or drive along this road and say we'll visit villages along the side of this road, because the sample of people you examine would not include anybody from this area here or anybody from this area here. So this means that the sample you examine should have, let's say it's 8,000 people you decide to examine, a quarter or 2,000 should come from this urban area, half should come from this arable area, and then the remaining 1 in 8 should come from, or quarter altogether, should come from these two areas here. You've then got a sample which represents the distribution of the population in terms of their geography and where they live. How to actually select a sample for a prevalence survey is absolutely key and vitally important in making sure that the findings you get are useful and meaningful. So, having done this population-based cross-sectional survey, bringing in members of staff from the university to help, epidemiologists, statisticians, maybe some social scientists, they found that one cause of blindness seemed to occur only in one area in Brunoland, and another condition only seemed to be affecting children. So another question to you is it important to know this? And if so, why is it important? So the survey was done, and this is what they found. Perhaps not surprisingly, diabetic retinopathy, glaucoma and cataract were all causes of blindness in the city. Many parts of the world now are experiencing an epidemic of diabetes, which is principally in urban areas, but increasingly in rural areas. So diabetic retinopathy you'd probably only find or primarily find in an urban component of a population-based survey. In these areas here, there was no diabetic retinopathy, and glaucoma and cataract were the most important causes of blindness. But over in this area here, there is also trachoma and vitamin A deficiency. So my question to you just now is, why is it important to know that there are these different causes in different places? And of course the most obvious cause is so that services can be targeted to the subset of the population who are most affected. So you'd want to set up a service for diabetic retinopathy focusing in the city. Trachoma, the SAFE strategy, would need to be rolled out in the arid area, as would vitamin A deficiency for children, but you need services of high quality for glaucoma and cataract to serve the whole population of that whole region. So understanding what is the epidemiological term for this is the distribution of disease in a population is very important for targeting services and for allocating resources. Sometimes it's also very useful if there's a disease where the underlying cause is not known, which is largely not the case in eye care, but if there is a disease where you don't actually understand why the disease is occurring, if it's only occurring in one geographical area, for example, it may give you some clues that there may be risk factors in that part of the region which aren't existing elsewhere, and so it can generate ideas and hypotheses about the underlying causes of disease.